discovering the muscular system. Those are the learning objectives for this lecture. Please take a moment and review them. Let's review types of muscle tissue. And the types of muscle tissues were introduced in chapter 4. And back then, we established already that we have three types of muscle tissue. We have the skeletal, the smooth, and the cardiac muscle. And we are looking at the skeletal muscle. It looks like heavily striated. That's probably the most pregnant type of characteristic of the muscle cell. Muscle cells are usually very long, cylindrical, and they have this type of striation that is the result of special type of proteins, protein threads that will position themselves in special patterns inside the muscle cell because they serve a certain purpose. Now, during development, the one muscle fiber or one muscle cell develops out of precursor cells that are called myoblasts that will fuse together and will form those long and large and multinucleated cells. So the skeletal muscle is under the control of the nervous system and is voluntary or somatic. It's under our conscious control at any given moment. This type of muscle tissue will have a characteristic of contractions that are rapid. Both the contraction and the relaxation is the same. The muscle cell will attach itself to bones, and the action of the skeletal muscle will produce movement at the level of the joints. Now, there are a few exceptions. The muscle of abdominal wall are partially attached to other muscles, and some muscles of face are also attached to other structures as skin. Skeletal muscle makes up to about 40% of our total body weight, depending on how much we are training, and is composed of more than 600 individual skeletal muscles. Despite the fact that they may have different structures and distinct structures, they usually act as a group to execute certain body movements. To compare and contrast skeletal muscle, the smooth muscle makes up the walls of the hollow body organ, as the blood vessels or respiratory or digestive system, has a pattern of contraction that is involuntary, is not under control of our conscious nervous system, does not have this striated pattern, and usually when we are looking at the microscope, we see short, narrow cells with only one nucleus. Another part where we can find smooth muscles is in those places in our body that the fibers will be disposed concentric in tiny concentric rings that will make up for what is called the sphincter that can regulate the diameter of an opening. Those cells contract and relax slowly, and on the other hand, they can remain contracted for a long time as opposed to skeletal muscle cells. The third type is the cardiac muscle, and the cardiac muscle is also involuntary and makes up for the heart's wall or the myocardium, the muscular layer of the heart, and while contracting, this muscle is creating the pulsation type of movement that the heart is making. The cells of the cardiac muscle seem to be striated almost like those of the skeletal muscle. The difference, the way that they differ from the skeletal muscle is the fact that they have only one nucleus per cell, and the striation is the result of a type of branching interconnections. So the membranes between those cells are highly specialized And this is in order to allow for electric impulses to travel, especially very, very rapid through them. So a contraction can be coordinated and transferred to all the cells almost in the same time. And because of that, those specialized membrane regions appear as dark lines between the cells, and they are called intercalated discs because they look like they are inserted between the cells. This slide is summarizing the compares and contrasts between the smooth cardiac and skeletal muscle. Question number 1. Which type of muscle tissue is striated and involuntary? Cardiac, intercalated, smooth, or skeletal? The muscle tissue that is striated in involuntary is cardiac. Before we are moving into a more in-depth understanding of the skeletal muscle structure, let's describe what's on the outside. On the outside, we have a few membranes, and they are called fascias. Those are fibrous connective tissue, and we have two types of those. We have the deep one that is most not expensive but extensive, and the main function of the fascia is to hold muscle together and to support the muscles as groups and to make them work as a complex continuous system. And in terms of layer, we have an outer fascia, an intermediate one, and an internal one. Another type is the fascia, is the subcutaneous fascia that lays inside the subcutaneous layer. It's somewhere in between the skin and the deep fascia, and it has an outer layer that is the fatty layer towards the fatty tissue, and an inner layer that is an elastic type of layer. Another type of fascia is what is called the subserous fascia, and it represents the internal layer of the deep fascia and the serous membranes inside the cavities. Now, those fascias will define what is called the fascial compartment, will separate the groups of muscles in certain very well delimited compartments, where we have the group of muscle with nerves and blood vessels that will serve them. And that makes that group extremely efficient to work together. However, whenever there is a trauma that involves that group of muscles, muscles will respond to any type of injury. And the typical one for that would be a crash injury to a limb. The muscles will respond by accumulated fluid inside of them, by developing what is called edema. As a result of the edema, the size of the muscles will increase. However, the fascia is totally inelastic, it's fibrous, and it's tough and not having any ability to expand. As a result of that, when the volume of the muscle increases, that volume will put some pressure on the nerves and on the blood vessels. As a result of putting pressure on the blood vessels, the blood support, the bloodstream will be compromised, and we may observe in a compartment syndrome the effect of tissue death as a result of lack of supply of oxygen and nutrients. The treatment for compartment syndrome is what is called a fasciotomy. What we do very wide and very long openings in those fascial compartments, allowing the muscle to expand to the outside, even outside the skin, and until they heal, and only after that we close those incisions. Another type of membrane will be what is called an aponeurosis, and that's a special type because it will bind muscle to muscle, and is very specific for the abdominal muscles, that they are not always attaching to a bone. So the muscles are made out of individual muscle fibers or cells that are arranged in what are called bundles or fascicles. And those are held in place together with a dense connective tissue. So if I'm going from the the deepest layer outside, the first layer will be the endomysium, the deepest layer of the connective tissue that surrounds the individual fibers within the fascicles right here. The next one will be what is called the perimysium, and you can see it over here. And perimysium is the connective tissue that surrounds each fascicle that has inside more than one muscle fiber. And on the outside, we'll have what is called the epimysium, which is that connective tissue sheath that encases the entire muscle. The epimysium forms actually the innermost layer of the deep fascia, which is very, very tough. The epimysium will fuse actually with the fascia and become what is called a tendon at the end of the muscle that will insert it on the muscle, on the bones. Now, just to repeat and emphasize a little bit about terminology. Endo means within, endomysium, the layer from within. Peri means around, and epi means outside or the above. So if you will click the link in red, this will take you to a short movie on YouTube that you can watch regarding the basic muscle structure. So to review the structure, we have the bones that will connect their tendons to the muscles. The muscle cell will have on the outside the inside layer of the out of the deep fascia that will be the epimysium that encases the whole muscle. That will send septums inside, separating the muscle into fascicles, and each fascicle is contained in a perimysium layer, and you can see that in between those fascicles we have arterioles and venules that will support the muscle with oxygen and nutrients, and the perimysium will send septums or walls, separating walls inside each fascicle, separating each cell and encasing each muscle cell with what is called endomysium. And if you look immediately under the endomysium, we have the muscle cell outer membrane, cell membrane that is called sarcolemma. The cytoplasm of the muscle fiber is called the sarcoplasma. And you will see how in a second we'll discuss the internal structure of the skeletal muscle in terms of organelles and whole internal structure. So this is actually showing you a microscopic view of the muscle cells, and it's showing you the innermost layer of connective tissue in the muscle. So when we are looking at the skeletal muscle fiber as a single muscle cell, you see that the cell is covered by the cell membrane in the situation of the muscular system. It's called a sarcolemma. And inside we have the sarcoplasm. So those cells are thin, long, cylinder-shaped, and tapered at the end. They are covered by sarcolemma, as I said, and inside they have a tight structure of myofibrils. And those are parallel strands made out of what is called myofilament. And we have two types of myofilaments. We have the myosin, that is the thick type of fibril, and we have the actin, that is the thin type. And there's an alternating of dark and light bands will make out for the striation that we see, and you can see here the dark and light bands on those myofibrils. Now, the functional unit of the muscle cell is what is called the sarcomere, and they are repeating section, and I will show you in a second how they look. So again, we are summarizing how the muscle cell looks like. We have on the outside the sarcoplasm. We have the myofibrils with the alternating dark and light bands. They are made out of myofilaments. On the outside, in between the sarcolemma and the myofibrils, we have a multitude of nuclei. And because the muscle cell is such an active type of structure, type of tissue, and is producing movement, it makes sense to have a lot of mitochondria that will allow for releasing the energy when needed. So the sarcomere is the functional unit of contraction in a skeletal muscle fiber and is made out by an alternation of thick and thin filaments. The thick one will make up for the dark bands, they're called myosin, and the light bands will be made out of actin. In addition to those thick and thin myofilaments, we have two regulatory proteins that will regulate the way that the muscle is able to contract or not. And those are called troponin and tropomyosin. So the sarcomeres will contract through a mechanism that is a sliding type of mechanism. The myosin needs to bind to actin and to form what is called a cross bridge. There is some stored energy, mainly in the mitochondria in each of those muscle fibers. And the myosin will use the stored energy to pull the actin filaments together within the sarcomeres. And as a result of that, the cell will shorten. In order to detach the myosin heads and move them back into the position for another power stroke to produce another contraction, I will need a new molecule of ATP, and the ATP molecule is the unit of energy storage in our body. Calcium is a critical element in the process of contraction of the muscles, and the action potential for a muscle cell to contract will release the calcium from the sarcoplasmic reticulum. Once the calcium is released, it will bind to one of the proteins that is called troponin. The troponin, as a result of that, will displace the tropomyosin from the binding sites, allowing for the myosin heads to form a cross bridge with the actin. And as a result of that, a contraction will occur. So you can see here how the sliding filaments are contracting. What's the mechanism of contraction? And you can see in the image labeled A, you can see a sarcomere when it's relaxed. And you can see how the thin filaments are the actin and the thick one are the myosin. Once they contract, myosin, it's pulling in image B, the cross bridges will form and the actin filaments will be pulled in by the myosin, resulting in a contraction. Once the muscle relaxes back, the myosin will return to normal position. A neuromuscular junction is that point at which a nerve fiber will contact the muscle cell. And there is, if you really look into this, you will see that the muscle fibers and the nerve endings do not actually come in full contact with each other. And in order for an impulse, an electric impulse to be transmitted to the muscle and produce a contraction of the muscle, there is a need for a chemical signal that is called a neurotransmitter. And that will be released from the neuron and will result in a stimulation of the muscle fibers. The specific neurotransmitter that is used for the skeletal muscle is called acetylcholine, and we usually abbreviate it as SCH. And we can find it pretty much everywhere in our body. Now, the neuromuscular junction is what is called a synapse, a point of communication between a neuron and another cell. The synapse term comes from Greek and it means no clasp. And this is because there is that tiny space, what is called the synaptic cleft. And you have here a detail of the synaptic cleft where you can see that actually they do not touch each other. They kind of hover over each other, and allows that cleft allows only for neurotransmitter to travel and transmit the produce the transmission of the impulse. The muscle cell receiving part, the level of the membrane where the muscle receives the signal, is called the motor end plate. Now, once an electric impulse reaches the nerve ending, those neurotransmitters will be released in the synaptic cleft. In the synaptic cleft, the acetylcholine will float around, will spread, will get to the motor end plane, and will bind to the receptors over there. As a result of binding with those receptors, action potential in the muscle will be created that will spread very quick along the sarcolemma and will generate the contraction in the whole muscle. When we talk about the muscle contraction process, we actually talk about one of the most important properties of the muscle tissue, and that is contractility. And that represents the muscle cell capacity to change its shape, to shorten by becoming thicker. So each myofibril is made out of many threads or myofilaments that are, again, made out of actin and myosin. The filaments of actin, again, they are thin and light, while those of myosin are thick and dark. And they present themselves in alternating bundles within the myofibril. And you can see again how they overlap. And if you really look into the mechanism of movement, you can see that the muscle, when shortens itself, becomes bulkier because it's just the relative movement of those two myofibrils against each other. None of them is changing their length actually. To summarize the contraction and relaxation, the muscle contraction is the result of actin and myosin changing their relative position against each other while not changing their length. The contraction is the result of the stimulation from the motor neurons living in the spinal cord in the anterior horns, and for that to happen, we need to have what is called a myoneural junction or a neuromuscular junction. Now, keep in mind that one plate, one motor end plate, which is that area, that sarcolemma place where the neurons will attach, can have more than one axon branch, and they make up for what is called a motor unit. So the motor unit represents that single neuron and all the fibers that neuron will stimulate. The muscle fibers can be scattered throughout the muscle, and usually we have small motor units whenever we are having a need for fine movements, while the large motor units will be used for broad movement that do not ask for a finesse type of activity. Again, the electric signal or the action potential that comes from the neurons will stimulate the release of a chemical signal that for the striated muscles is acetylcholine. This chemical signal, acetylcholine, will bind to receptors and will induce an electrical signal or action potential now at the level of the muscle cell. And that's how the electricity is passed from one cell to the other. Again, this is a detail of your neuromuscular junction or the synapse between the neuron and the skeletal muscle. And you can see the synaptic cleft in here. This is a microscopic imaging of the same picture here. This is a drawing, while this is the actual electron microscopy of it. And you can see how the motor axon spreads to more than one skeletal muscle cell. Again, to summarize the neuromuscular junction, that will allow the motor neuron to stimulate the muscle becoming excited by an electric impulse. As a result of that, we'll see a muscle contraction. In order for that to happen, we need to have acetylcholine to be released from the motor neuron into the synaptic cleft. Acetylcholine will diffuse across the synaptic cleft toward the motor end plate and will bind to the motor end plate, stimulating the sarcoplasma and generating an action potential at the level of the muscle cell. Question number 2 is asking you a single neuron and all the muscle fibers it stimulates comprise a motor end plate, motor unit, neuromuscular junction, or a synapse. A single neuron and all the muscle fibers it stimulates comprise a motor unit. If we need to summarize again, and I know that I said it probably 6 times in 6 different ways, acetylcholine is essential and needs to be released into the synaptic cleft at the neuromuscular junction, will bind to the motor end of the plate and produce an action potential. Once the action potential is generated, will travel through the sarcolemma of the cell to the sarcoplasmic reticulum. Stimulated by the impulse, the sarcoplasmic reticulum will release calcium into the sarcomere cytoplasm. As a result of that, the calcium will shift troponin and tropomyosin off of the thin filaments, so the binding sites on actin are exposed and can connect with the heads of myosin. Once the myosin heads are binding to actin, cross bridges will be formed, and using stored energy, the myosin will pull actin filaments together and the cell will shorten. In order for a new power stroke to happen, I will need new ATP molecule to detach myosin heads and move them back to position for another contraction. Muscle will relax when stimulation ends and calcium is pumped back into the sarcoplasmic reticulum. Now, please, I want you to remember how essential calcium is for this process, because if you remember that, you will understand how we create medication to modify ways that our muscles contract, and that's used especially for the cardiac muscle. To change the way that our cardiac muscle contracts, we have what is called calcium channel blockers that will block hyperactivity of the heart. So, question number 3, the 2 filaments that form cross bridges are actin and troponin, tropomyosin and myosin, actin and myosin, or troponin and tropomyosin. And the answer is actin and myosin are the 2 filaments that form cross bridges. Now, we just decided that the muscle contraction can be done only if we have ATP. And ATP is the energy source. ATP provides energy not only for muscle contraction, but also for any type of other active processes in our body. So in order to generate ATP and to have them synthesized, we need nutrients. And the easiest type of nutrient that the body can use will be your carbohydrates. And we have them in a stored form in our body, mainly in the liver as glycogen. And glucose is freely available in our blood vessels as the usable form. Whenever the levels of glucose are low in our bloodstream, the body will release from the stored form of glycogen. Another type of nutrient that the body can use to produce ATP is the fats. And the stored form is called triglycerides, and they are stored in our fatty tissue with fatty acids as the usable form. Now, to produce energy, we need to burn those nutrients. And burning the nutrients can be done only if we have enough oxygen. The oxygen is transported in our body by hemoglobin in blood and can be stored in quite big quantities in myoglobin in the muscle. Myoglobin is very similar to hemoglobin. It's a protein that is localized and stored in the muscle cells, and it's able to bind and store oxygen for whenever the muscle will need it. In addition to those, I will need a place where I can do the burnings, where I can uh, process the nutrients in order to generate ATP. And that place where I can produce energy is called mitochondria. And that's why muscle cells that are so active need such a big amount of mitochondria. I have two types of processes through which I can produce ATP. One is called aerobic respiration and refers to the cellular respiration. And it's not typical only for your muscle tissue. It happens in every kind of tissue that we have in our body, but we are describing it for the muscular tissue. So if you follow this little graph, you will see that glucose can become pyruvic acid in the absence of oxygen and will release some ATP. Pyruvic acid, once entering the mitochondria in the presence of oxygen, or fatty acids in the presence of oxygen, will be burned inside the mitochondria, and as a result will have ATP. See this ATP as your stored energy, like the batteries, and as a end result or waste product of metabolism, will always have in our body CO2 and water. So you can see that those are my main types of, I can use glucose, pyruvic acid, or free fatty acid, and those are my main sources of energy. Once we are producing ATP in the presence of oxygen, you can see that per each molecule of glucose, I can produce 36 ATP molecules, quite a lot. And remember this number, 36. This is a process that can ensure energy for that area, for those cells in the body for hours. Now let's look what happens if the muscle performs and needs to be active in the absence of oxygen or at very, very low levels of oxygen at the level of the tissue. The generation of energy still happens. So the glycogen will become glucose. And in the absence of oxygen, we can break down glucose into pyruvic acid and some energy. And pyruvic acid will be easily and quickly converted to what is called lactic acid in the muscles. Now, as a result of that, we produce only 2 molecules of ATP per each molecule of glucose. And in addition, we have what is called lactic acid. So what you see is that instead of producing waste products that the body has a way to eliminate them very quick, like CO2 and water, we end up with a byproduct that the body will need to deal with it in the future, which is the lactic acid. More than anything, is an acid, and if you remember, our body doesn't like the situation of having acidity around. In addition to that, the energy provided is very short term. Now, thinking about that and comparing to the aerobic type of glycolysis, when we produce 36 ATP molecule per each glucose molecule burned, you can see that anaerobic type of energy producing is very efficient if we want to lose weight, right? And that's actually what happens when you're going to the gym and you're practicing, and at a certain point, not only that you feel tired, but you also feel sore. And the soreness is the result of accumulation of lactic acid inside your muscles. It's an acid. It's a weak acid, however, still an acid, and will make you feel that soreness in your muscles that a lot of time it becomes accentuated 24 hours after you're exercising a lot in the gym, because the lactic acid production will continue even after you stop your exercising. So this is a table that will summarize your sources of ATP. And you can see that if we are using, if the muscle is using anaerobic glycolysis, we can use glucose without oxygen. The speed of producing energy is quite fast with small amounts of ATP generated, and it happens in what is usually called an intense exercise. We have aerobic metabolism that would use pyruvate for that, or fatty acids in the mitochondria in the presence of oxygen. And the speed is a little bit slower, however, generates a large amount of ATP. And it happens in those exercises that are more endurance and not cardio type of exercises. What will be some effects of exercise? So regular exercise definitely will result in some changes at the level of the muscle tissue. And the muscle cells usually adapt to regular exercise by increasing the workload. Now, those changes will depend on the type of exercise that you're performing. When you're doing resistance training like weightlifting, um, the muscle will increase in size or will go through a process that is called hypertrophy. And that's common for those bodybuilding type of athletes. Larger muscles will contain more myofibrils and can make more cross bridges, so they will generate more force. So in addition to that, by performing under resistance training, again, weightlifting, we will increase our muscle stores of creatine phosphate and glycogen, so the muscle can use them as in the process of exercising through anaerobic metabolism and be able to generate larger amounts of ATP in a short time, because remember, the aerobic type of producing of energy is very slow. In addition, the muscle hypertrophy will be stimulated by hormones, and especially the male sex steroids. Um, Now, along with the hypertrophy, there is, whenever we exercise, there is a process of vasodilation in the fibers that will be, along with the other cardiovascular changes that will be um, as a result of an increased cardiac output to sustain the need of oxygen and blood flow at the level of the muscle. So as a result of exercise, the muscle will become stronger. In regular exercises, exercising, the patient or the person will improve breathing and will have a better respiratory efficiency. by using the respiratory muscles for that. Other effects of exercise will be obviously weight control and stronger bones. Because if you remember from previous chapter when we discussed bones, bones become stronger if they are exposed to weight-bearing exercises. So the more we exercise, the stronger the bones will become. Myoglobin is the muscle cell compound that is able to store oxygen. We'll define a little bit now types of muscle contraction. So let's define what it is, the muscle tone. So muscle tone refers to that quality of a muscle to be at all time in a normal state a little bit contracted. The maintenance of this tone or the tonus is the result of a nervous system that keeps the muscle in a constant state of readiness for action. Whenever we have a muscle that is not used or little used, will become weak and lacking the tonus. And the typical example that I can give you is back in the day when we used to put the patients that had a limb that was fractured, the bone that was fractured in a cast, and the cast was usually hold on place for 4, 6, 8, and even more weeks. When we removed that cast, the muscles for that limb usually look completely atrophic and small and flabby and weak. And patients were requiring long-term physiotherapy to recover from those events. Now, let's look at different types of contraction. We have what is called an isotonic. Remember the tonus, that quality of being a little bit contracted all the time. So isotonic contractions, in those, the tone or the tension in the muscle stays the same. The only thing that changes is the muscle length. So the muscle will thicken itself, will bulge to accomplish the work. And we have two types of contraction in this type of muscle contraction. We have two subtypes. We have what is called the concentric contraction, and those are the familiar one. We are used this type of contraction most of the time because they are producing changes in position. In a concentric contraction, the muscle as a whole will shorten to produce that movement. As an example, flex your arm at the elbow level to pick up a dumbbell or a heavy can. The other subtype will be what is called an eccentric contraction, and in those contractions, the muscle length lengthen as it exerts the force. Let's say, imagine lowering the dumbbell or a heavy can. So the concentric type of contraction is typical for flexion of the muscle, while the eccentric contraction will be typical for an extension. The opposite of the isotonic type of contraction is what is called an isometric. And in this one, the muscle length will not going to increase or not going to change. What changes is the muscle tension. So the typical example for that will be pushing against an immovable force will produce an isometric contraction, as trying to push on a wall, or trying to push the palm of your hands hard against each other. We have three main muscle functions, and those are skeletal movement, we have posture maintenance, and we have heat generation. Let's look at the muscle and body movements. Muscles are attached to at least 2 points. They have an origin that is attached to an unmovable bone, and we have the insertion that is the attachment to a movable bone. As in this example, where you have the biceps, where you see the origin is usually wide on like a resistance point on the bone that will not go, or the segment of the body that will not going to move, and we have the insertion of the tendon that connects to the bone or the segment that will be moved, and you can see how it becomes slender and becomes a well-defined tendon. So again, when we are increasing the muscle usage, we'll have an increase in muscle size. A hypertrophy will result in an increase in muscle strength, an increase in muscle efficiency, and up to a point, because the muscles may become fatigued and more resistant to effort at a certain point. Question number 5. In anatomic lever systems, the fulcrum is bone, bursa, insertion, or the joint. Joint is the fulcrum in the anatomic lever systems. How do we name and describe the muscles in our body? We have a few ways of doing that. We can name them by location, as a bone that's near, for example, temporalis. We can call them or name them by size using terms as maximus, that means the largest, or major, means also the first. By their shape, such as orbicularis, that means circular, or deltoid, that means triangular. We can call them by the direction of the fibers. We can call them rectus, as the straight direction of the fibers. We can call them by the number of the heads, biceps, or the number of the heads are the number of the attachment points. It will be indicated by the suffix seps, as biceps, triceps, quadriceps, or by their action. They can be flexors, adductor, abductor, or levator. Levator means a muscle that lifts something. Flexor obviously will do flexion, extensor will do extension. Please try and review the superficial muscles um, in this picture. There is not a lot for me to explain. This uh, part of the lecture now is pretty much self-explanatory. I don't want to sit now and just name every single muscle. Please stop here the presentation and make sure that you familiarize yourself with the muscles that are presented here and which area of the body they belong to. Just like in the previous slide, please stop the presentation here and become familiar with different types of muscles and which area they belong to. Those slides are very descriptive. Head and neck, become familiar with the muscles of the head, the face, and the neck. This table will summarize some of the muscles of the head and the neck with their origin, insertion, and functions. Continuation of muscles of the head and neck um, um, with name, origin, insertion, and function. This is a review of the previous two slides, focusing now on the shoulder and arm muscles, both from the anterior and posterior um, um, aspects. Table summarizing the muscles of the shoulder and the arm with origin, insertion, and functions. Muscle moving the forearm and hand. Table summarizing muscles of the forearm with name, origin, insertion, and function. Muscle moving the hand and fingers. Muscle of respiration, not a lot. Please observe that the diaphragm is a striated muscle. Abdominal wall muscles. Muscle of the female perineum. Muscle of the thorax. Abdominal muscle. Muscle that moves the leg and thigh. A detail in the muscles of the thigh, both anterior and posterior view. Muscles of the foot, anterior and posterior view. Muscles that move the foot, detailing origin, insertion, and function. Tibialis anterior is the antagonist to the gastrocnemius. A review of the smooth muscle characteristics: has no striation, has a spindle-shaped type of cell with a single nucleus. They are involuntary, so no conscious control for those, and they make up for the muscles found in the hollow organs. They move, their contraction creates a wave-like motion that is called peristalsis. And there is a special type of smooth muscle that is called a multi-unit smooth muscle that can be found in some blood vessels and is the main component of the iris. A little bit about the smooth muscle contraction. So they also have actin and myosin. The contractions will be stimulated by a membrane impulse, just like in the striated muscle. Both in the smooth and striated muscle will be calcium ions will be released, and they are playing a key role. Both types of muscles will require energy from ATP to create the contraction, and acetylcholine will be involved in both types of muscle. The difference between the smooth and striated muscle is the fact that the smooth muscle will not contain the troponin protein, will contain a different one that is called calmodulin that will activate the contraction of actin and myosin. Acetylcholine is not enough for a smooth muscle contraction. It will need the help of another substance, another neurotransmitter that is called norepinephrine. Hormones may affect the smooth muscles by stimulating or inhibiting their contractions. The smooth muscle fibers are stretched by contractions, and by doing that, they can become overstimulated, like in stretching the stomach after having a hefty meal. Just by stretching the muscles in the stomach wall will stimulate contractions, and the stomach will try to empty itself. Smooth muscle will contract and relax slower than the skeletal muscle and can sustain contractions much longer using the same amount of ATP as the skeletal muscle. Quick review of the cardiac muscle characteristics. It has striation as a result of the intercalated discs that join together the muscle cell and allow for a quick transmission of the impulses from one cell to the other. It's an involuntary type of muscle, and the cells have common characteristics with a smooth muscle. They have a single nucleus, however many mitochondria, because of the continuous activity of the heart and the fact that it contracts actively all the time. For the cardiac muscle contraction characteristics, they have a rhythmic pattern of contraction with a longer refractory period. The cardiac muscle will have a myogenic type of contraction that is spontaneous, involuntary, however controlled by the autonomic nervous system. We'll discuss that in the future chapters. We can study the cardiac muscle health and activity by using two types of tests. One is called an electrocardiography and one is called electromyography. Electromyography can be used also for studying the health and the ability to contract the activity of the skeletal muscle. Effect of aging on muscle. Usually aging for the musculoskeletal system starts in our begins around age 40 and is characterized by a continuous and gradual loss of muscle cells. In addition to that, our muscles will lose their force or power that they had before, especially if they are not exposed to repeated and consistent exercise. There is a tendency to flex hips and knees to positions that resemble and they are closer to the fetal position in terms of contraction. And there is a decrease in height, mainly based on the fact that our vertebrae will lose bone tissue, if you remember from previous chapter. Just to have a few terms that will allow us to have a common language. We call a spasm any type of sudden or involuntary muscle contraction, which usually is painful. We call a colic a spasm of a visceral muscle. Let's say when we say that we have a bellyache, it's usually a spasm of the bowel. We call a seizure or a convulsion a repeating spasm that is created as the level of the skeletal muscles. And that usually is generalized. It happens in all the skeletal muscle. A cramp is a strong and painful muscle contraction, is usually seen in legs and foot, is likely to follow some type of sustained activity, also can be seen in nerve compression or dehydration, or will have what is called the Charlie horse. Probably you've heard that term. That is a cramp in a muscle, most commonly in the leg, and that contraction can be related to electrolytes imbalances. Muscle atrophy is loss of tissue that can decrease in size, especially when that's an area that is not used. As we can see in a limb that was put in a cast for a long time, or in a patient that has any type of stroke or paresis that is not able to move a certain part of the body. In terms of pathology of the musculoskeletal system, we define strains. A muscle strains whenever it's overstretched or overused. And as a result of that, at the level of the muscle tissue, we see micro tears between the muscle and its tendons. As the result of those micro tears, we have micro bleeding and inflammation inside the muscle. And as a result of that, we may have that picture of a clinical picture of pain, stiffness, swelling, and even sometimes bruising over the torn region. Another pathology of related to muscle injury is the delay onset muscle soreness. That it's a specific type of stiffness and pain that show up later, 24 to 48 hours after an intense workout, and is a result of inflammation also produced by micro tears in the muscle tissue. And a most extensive and life-threatening condition is rhabdomyolysis, that is a result of necrosis of the muscle, extensive necrosis of the muscle, with release of waste product from this necrosis, waste products as creatinine into the bloodstream. And as a result of that, the kidneys can be damaged because they are overwhelmed with the amount of waste that they need to process. Muscle diseases. We talk about muscular dystrophy, which is a whole group of disorders where there is a deterioration in the aspect, in the function of the muscle. However, all those muscular dystrophies will have an intact nervous system. And those disorders usually have a progressive type of development, and they may progress at different rates among each other and from one patient to the other. As an example of that, we have Duchenne muscular dystrophy. It's an inherited form of disease that is exhibited mainly in male children, and is a result of a deficient protein. They are lacking some genes to create the correct protein. Usually, it starts very early in age. They have a life expectancy of not more than 25 years. It's very rare that we see people living longer than that. This muscular dystrophy affects all the muscles in our body, including the respiratory muscles. And if you remember, the diaphragm is one of them. So usually those patients will become dependent on a ventilator and will die from complication of being ventilated for a long time. Myasthenia gravis, or the chronic muscular fatigue, is a condition that may affect adults and usually starts at the level of the head and develops down. What we can see in those patients is a drooping of the eyelids, like ptosis, as an early sign. They look like they are tired, but it's just the tiredness inside the muscles. In this condition, there is a loss of acetylcholine receptors in the muscle cell membranes. So, and this is a result of an autoimmune response from the patient. The patient autoimmune system will attack those receptors and will destroy them. Without those receptors, the acetylcholine will not going to be able to bind to the muscles, muscle fibers, and will not going to produce a contraction. Myalgia, or muscular pain, myositis. Itis is the term of inflammation of a tissue. Fibrositis is inflammation of the connective tissue, especially at the level of the muscles and the joints. And as a combination of those, we have the fibromyositis, which is acute or severe pain whenever the patient is moving. However, we may see in patients that show up symptoms that manifest as chronic pain. Fibromyalgia is a syndrome that is manifesting with widespread muscle aches, tenderness, stiffness, fatigue, sleep disorders. It's a condition that is very hard to diagnose and was described only in the probably 10 years, was not really recognized before, and it's very hard to treat it. It seems to be the result of an immune response that reacts and destroys the patient's own tissues. Now, looking into other structures, we have tendinitis. Again, itis is inflammation. Tendinitis is an inflammation of muscle tendons and their attachments. Is very common in athletes and in people that are training themselves frequently and extensively. We have plantar fasciitis. It's a form of tendinitis that involves the thick fascia, bands of connective tissue on the bottom of the foot. Usually causes for these conditions are obesity, prolonged weight bearing, like standing on your feet, being exposed to this type of work environment and wearing improper shoes, overuse of the feet as in runners. Tenosynovitis involves the synovial sheath that will cover the tendons. Is very common in women in their 40s after injuries or surgeries, and it presents itself with swelling and severe pain whenever that area of the body is moved. Shin splints is pain or soreness along the tibia, which is called also the shin bone, and they're the result of stress injuries. And some causes of shin splints are tendinitis at the insertion of the tibialis anterior muscle. Now, a few words about the tendons. Tendons are very poor in vascular supply, do not tolerate suturing well, tend to heal very, very slow, and when one of those tendons is completely destroyed, especially in professional athletes, it may lead to the end of their careers because they are very hard to fix them surgically. Healing of the muscle. In surgery, we like to spread the muscles rather than cutting them transversally in order to conserve their blood supply and nerves. And we like to do what is called blunt instead of sharp dissection. When we suture muscles, we try not to suture muscle itself, but only the fascia, and allow the fibers to reconnect and feel and heal themselves. Skeletal muscle. It's important to remember that it's not a dividing type of cell. Will regenerate from what is called myosatellite cells. Smooth cells, they do divide through mitosis, and the cardiac muscle do not divide whatsoever. Whenever there is death of cardiac muscle as a result of a myocardial infarction, there will, as a result, we will have a fibrous scar with no ability to contract in that area, with a loss of function for the heart.